Hello, my name is Jim Capretta. I'm a senior fellow here at the American Enterprise Institute, and I am very pleased to welcome you to today's virtual event on the future of Medicare's alternative payment models, including accountable care organizations. My special guest for this conversation is Michael Chernew, the Leonard D. Schaefer Professor of Healthcare Policy at Harvard Medical School. Mike is one of the nation's most respected health economists and an expert on the complex and varied payment models, including accountable care organizations, that have emerged in Medicare over the past decade. He's also the chairman of the Medicare Payment Advisory Commission, which advises Congress on Medicare's payment policies. He's speaking today strictly in his role as a health policy professor and not in his role as MedPAC, but that's fine. As his knowledge and expertise as an analyst and an economist are more than enough to make him worth paying attention to on all of these questions. The Biden administration took office earlier this year at an important time in the Medicare program. ACOs and other payment models have produced some results, good results, but they've been relatively modest. Even as the number of demonstrations have grown, some of the models work at cross purposes. And now there is some uncertainty about next steps and which models deserve to become the focus of renewed effort and special attention. These questions are emerging even as the Medicare Hospital Insurance Trust Fund is expected to be depleted of its reserves in a few years, several years, and as Congress is actively considering making changes to the program to expand its covered benefits and perhaps add more people to its enrollment. There's no better person, as I already said, to help us think through these questions than Mike. I'm very grateful he was willing to join us today for this conversation. In a moment, I will turn this over to him to make a short presentation outlining his views on this subject, after which he and I will explore the topic through a number of different additional perspectives. There's an opportunity at the end of the program today for some questions from those who are watching. Please submit questions in one of two ways, either to an email address, cameron.tarbell@aei.org, or on Twitter at #AskAEIHealth. Thank you, Mike, again for agreeing to come to have this conversation today. I'm going to turn the floor over to you now.
Jim, thank you. I am going to share my screen. It is always wonderful to talk with you, and it's particularly wonderful to be able to engage with the people that are in the audience. So I am thrilled to be here talking about a topic which is indeed true to my heart. As you mentioned, I'm going to be talking in my role as a professor. MedPAC is 16 commissioners plus me, and we're not, it's a consensus process. This gives me a little more freedom to tell you exactly what I think when I'm speaking for me, but I'm happy to discuss where I think MedPAC is going. And again, as you mentioned, we're going to talk about alternative payment models. So let me start with the motivation. Why are we doing any of this? The core thing to understand and sort of is that there's a lot of inefficiencies in Medicare. We've known for literally decades since Jack Wenberg's seminal work that there's a lot of geographic variation in utilization that's not particularly correlated with outcome or quality. Increasingly, there's attention to low value care and overuse. I think this issue is going to be bigger with new technologies like telehealth. I want to emphasize, I do not believe telehealth is low value. I think telehealth offers an unbelievably important opportunity to improve quality and access. That being said, telehealth often also presents the risk of overuse, and how to manage telehealth in a world of fee-for-service payment is a particular challenge. And there's a ton of work. MedPAC's done a lot. Others, analysts have done a lot of work on issues related to inefficient uses of the site of care. A lot of that happens in post-acute care. There's a bunch of other related issues. The Medicare fee schedule, which I'm going to only touch on briefly, has issues that it pays differentially for the same service across the sites. So there's a lot of desire to make payments site neutral. And so the goal in APMs is to kind of address this underlying core problem of inefficiency in Medicare. So it's important as a foundation to understand that fee-for-service is broadly viewed as an impediment to eliminating those inefficiencies. In the Medicare program, to deal with a range of inefficiencies in the fee-for-service system, we have a bunch of clunky administrative rules, caps on, how many times you can have, how long your hospice stays can be, and a whole slew of other rules to try and prevent overuse of services, which are often administratively burdensome and difficult to implement. And so the challenge, and I'm going to talk about this mostly today, is if we can develop payment models that encourage efficient delivery of care, both the care that's delivered and the site where that care is delivered. Some general criticisms of fee-for-service. Before I jump into the alternative, it's important to know where we are. The first one is it incentivizes quantity rather than quality. Volume over value, I think, would be another way of saying that. It's hard to get the prices right. Medicare talks a lot, MedPAC talks a lot about updates, but of course CMS sets relevant prices, and there's always a debate about services that are overpriced, services that are underpriced. There's a lot of services. Getting the relative prices right is very hard to do. Payment is fragmented, so we worry about care coordination and handoffs between different types of providers. We've explored things like fees for care coordination. That's also difficult to understand because you have to define exactly what care coordination is. And more broadly, it's hard to impose accountability at a system-wide level because everyone is only responsible for the care that they're delivering. Despite that sort of well-known set of criticisms of fee-for-service, it's important to understand that other countries do make fee-for-service work. And in fact, almost all the alternative payment models are built on a fee-for-service chassis, a topic we may get back to in a moment. The way that other countries make fee-for-service work, in part, is to have very low fees. So that's basically what we've done in Medicare in terms of fee trajectory. So this is an old slide, but it captures, I think, well where we are for physician payments. So we had a system for paying physicians called the sustainable growth rate system. It was many things. It was not sustainable. And so we replaced it with a rule called broadly macro, which includes the MIPS system, which is a pay for performance portion of fee-for-service payment. What's often missed in that debate is the underlying base trajectory in MACRA is essentially flat. This slide goes out to 2042, and the base payment rates, the slide's a bit dated, but the base payment rates are scheduled to go up less than 10%. So the average payment rate for fees, in nominal terms, the average payment rate for physician fees in current law is basically flat. It's negative in real terms. We can debate whether that's sustainable, but understand in a moment, I imagine people will complain about alternative payment models. The alternative, at least the current law alternative for physicians, is essentially flat nominal fee updates between now and 2042 and beyond. For facilities, it's somewhat similar. Not quite as stringent, but the Affordable Care Act put in place a system known as the productivity adjustment. So prior to the Affordable Care Act, every fee schedule, all the facility fee schedules had built-in updates basically related to a market basket. And now the current law updates are the market basket minus a productivity adjustment based on multi-factor productivity improvements in the country overall. Now, whether or not healthcare can achieve the productivity gains of all the other sectors of the economy remains debatable. But the big point is the status quo with which you have to compare all the APMs I'm about to discuss is sub-inflation growth in provider fees. And given the fiscal challenges you laid out, Jim, and how long it took us to replace the sustainable growth rate formula, and the fact that when we replaced it with something with really flat physician fees, shows you it is going to be challenging, I believe, to put a lot more money in the system, although I must admit my understanding of fiscal discipline is less than I might have thought several years ago. That being said, that's sort of the backdrop for alternative payment models. So what's the current role for APMs? The idea is to create a payment model for providers that encourages lower spending and better quality, and this is important, allows the providers to share in the savings from waste reduction. So we know there's some waste, we want to eliminate that waste, and the goal here is to allow providers to share in those savings to basically compensate them for the fact that fees are going up, which is probably a particularly low rate and may not be sustainable. The goal is not necessarily to maximize savings for Medicare, although I don't want to de-emphasize the fact that savings are indeed important. The thing is, we're going to do these types of APMs in the fee-for-service, the traditional Medicare branch, and we're just trying to improve that part of payment. Typically, we'll use population-based payment models, think ACOs, or episode-based payment models, think BPCI, which is the Bundle Payment for Care Improvement Program, or CJR, which is the program for joint replacements. Those are the type of APMs we generally look at. If plans or other entities can do better than this, so this is in the sort of traditional Medicare sector. If other organizations can do better with a whole set of tools, think, for example, Medicare Advantage plans, that is wonderful. I'm a big fan of Medicare Advantage. I believe they can do a lot. They are free, as the current system is set up, to compete to get beneficiaries to voluntarily enroll. They can build their own payment models, create value however they would like. But the trick is, some of the constraints that Medicare Advantage plans use are not built in to the fee-for-service side of Medicare. And so APMs are not, the goal is not to make everything Medicare Advantage. The goal is to try and do better in the confines of traditional Medicare. The theory of alternative payment models is pretty simple. Efficiency requires flexibility in how inputs are used. So again, in Econ 101, you typically have capital and labor. No economist knows exactly what capital or labor is, but they're different. And they're just, they can be substituted in different ways to create output in the most efficient way. And they respond to the prices of capital and labor, for example. Healthcare services, the things that we often think are outputs of the healthcare system, are actually inputs. We're trying to produce health. So the question is, can we produce the same amount of health using fewer healthcare services? That's the nature of efficiency, and flexibility to substitute those inputs and then capture the gains from that efficiency is important. These new payment models give providers that flexibility. So if they eliminate a needless MRI, if they reduce a hospital admission that wasn't needed, if they can more efficiently use post-acute care, those are all using inputs differently, and some of the savings from that they can then share in, as opposed to in the fee-for-service system, where if they don't use an MRI, all the savings go back to the program. I wrote this term in something I published a while back in JAMA Health Forum, waste is an asset. So one of the underlying debates is, when we become more efficient, and given our fiscal challenges, I believe we need to become more efficient. The question is, who gets to keep the savings? That is an important underlying discussion that pervades all of this, although sometimes it's not explicit, and I want to make it explicit. I'm not sure who's actually pooling for dollars. But anyway, someone wants to get the savings. So Jim mentioned in a much more concise lit review than I will do what we've learned about APMs. So population-based payment models, ACOs, generally speaking, there's gross savings. It's pretty clear that you can change provider behavior when you do this. The savings, so again, this should be clear. In a shared savings model, the savings gets shared. And so just in case it's been a while since folks have been in kindergarten, the way that works is, you have a big thing and you share some of it, you're left with a smaller thing. So the net savings are always below the gross savings. But again, in ACOs, there have been positive net savings. My joke has been, if someone offers you $1 and gives you a dime, take the dime. In a moment, I'm going to talk about how I think we can do better. Episode-based payment models, again, often there's gross savings, not always. It very much depends on the episode. Certain ones like hip and knees consistently yield savings net, but there are a lot of variation in how episodes perform across the episodes. And remember, a 2% savings or a 5% savings on hip and knees is less than a 2% savings on a population basis, because a lot of our spending is not for hip and knees. There's been a lot of attention in primary care transformation models, think CPC+. The findings on gross savings are generally mixed. It's less known about net savings, but with mixed finding on gross savings, it's hard to get net savings. I focus a lot of my talk and a lot of my attention on spending. I'm not sure why. I get a feeling that's what a lot of the audience cares about, but that doesn't mean that I don't care a lot about quality. Quality is a really important component of this. It's just doesn't get quite as much attention, in part because it's hard to measure. But the bottom line is, none of these programs seem to have a huge effect on quality one way or another. There is some evidence that people in ACOs, commercial ACOs, have been more satisfied. Actually, I could point to some evidence that says disparities have gone down. But really, I think if you're going to be sort of skeptical, as economists are wont to do, I just think we don't see a big change in quality associated with all of these payment models, positively or negatively. So MedPAC had a recommendation. So again, I'm speaking as me, but this is the actual MedPAC recommendation published in this past June, which is the Secretary should implement a more harmonized portfolio of fewer alternative payment models that are designed to work together to support the strategic objectives of reducing spending and improving quality. That might be the first time I actually really read that in public. Somehow when you read it on the page, it seems smoother. Nevertheless, understand that when CMMI, which is the Center for Medicare and Medicaid Improvement, the Innovation Center, was founded, it was founded on a test and diffuse paradigm where they had a lot of models, they were diffusing a lot of models, and as Jim, you mentioned, sometimes they work at cross purposes, they complicate the world, and this they had 1,000 flowers bloom kind of philosophy. And part of the problem was a lot of flowers were blooming. Sometimes they were planted in the same hole. And so the goal with this recommendation was a little bit, in my opinion, to change the paradigm away from build more models, test them and diffuse them, to think strategically about how to set a group of models that can transform payment. And the reason that matters is the existence of any model influences the performance of the other models. If you test 3 things against fee-for-service and they all work, and you implement all 3 things, the results will not simply be the sum of what you got for each of the 3 evaluations, because they will interact with each other in complex ways. So you can't think of all the models as independent, and that's what this recommendation was designed to emphasize. So the question, of course, is, so that's kind of aspirational, that's true. What do you mean? How should CMS harmonize their portfolio of models? So to capture some other themes, instead of developing models in isolation, they should develop a group of models that are designed to work together. The models' financial incentives should be complementary and not diluted when they're combined. So for example, if waste is an asset and you divide that waste up amongst a whole bunch of groups, you change the incentives for any one group to do some of the actual hard work, and you need to be careful about that. And to the extent possible, you should develop models that have somewhat consistent features, things like spending targets and attribution. So overall, you're trying not to siphon away the savings from some models and give them to some other group, because that changes the incentives of that first set of models. How to do that is complex, and I have some ideas that I'm happy to talk about them. As they're my ideas, I'm not clear where MedPAC is going to go, but there's a bunch of key parameters, and we will be discussing this, MedPAC will be discussing this over the course of the year, and I spent a lot of other time thinking about these things. Parameters are things like how strong to incent participation. So on one side, people often say mandatory versus voluntary. I think we've realized in things like the ACA and the hospital price transparency rule that mandatory really depends on how strong the penalties are. So I don't think of mandatory and voluntary. I really think about the incentives for participation. How strong should they be and for whom? The most important thing, where we're doing a lot of work now, is how the benchmarks should be set. These models, I think, can change behavior, but the net savings depend on the rules for how the benchmarks are set. Participation depends on how the benchmarks are set. Benchmark setting is, in my view, probably the most important of these issues, although, again, these topics are all interrelated. How much risk to impose? There was a big push to impose downside risk. I understand why, but not all groups are suitable for downside risk, at least not significant downside risk. So we have to think about the heterogeneity of the delivery system and how much risk to impose. One of the challenges that all of these models face compared to, for example, Medicare Advantage is attribution. How do patients get assigned to providers? There's a lot of noise there, a lot of complaints about that. How well can we do that matters. I think the part of this whole path to alternative payment models that keeps me up at night is the risk adjustment system. By the way, it also keeps me up at night about Medicare Advantage. So maybe I'm just not sleeping well, but the point remains, as you move to these broad population-based models, getting the risk adjustment system working really matters. And we could probably have a whole other webinar on challenges with risk adjustment. And then the last one relates to how do we combine, I mentioned harmonize in the very beginning. And so what do I mean by that when there's alternative payment models that are population-based and some that are episode-based? How should those actually be combined? Again, I'm happy to give you my ideas on how to do that. The broader point of the recommendation is that needs important thought. Different reasonable people will vary about how you should do that, but you need to think about how they're going to be combined as opposed to just launch them independently. So that's my summary of where we're going. The thumbnail point is we will spend a year on MedPAC, and I think a lot of people besides MedPAC will spend a lot of time in the near future thinking through these parameters, and hopefully what will come out will be something that's transformative that will allow the delivery system to survive on a very low on a lower revenue growth trajectory than otherwise projected, and still deliver high quality care. And to square that circle, do it by achieving the care efficiencies I talked about at the beginning. So Jim,
Thank you, Mike.
Sitting, happy to chat.
Thank you, Mike. That was terrific, as always and as expected. I have some questions. Let me just tee it up. I don't know if the audience can see me yet, but I think they probably can. Oh, there we go. So let me tee up a couple questions for you that are based on some of the points you just made. First, I want to go back to this question of attribution and how the beneficiaries interact with the ACO model. When I've had discussions with delivery system folks who run these kinds of complex enterprises, they do say very frequently that their task is complicated by the fact that knowing exactly who they're accountable for can sometimes be a moving target. And of course, on the other side of it, the beneficiaries more or less don't know that they're in sort of a managed model when they get attributed to an ACO. And I kind of always think about the name itself, accountable care organization. I think, well, accountable to who? You know, it's the providers being accountable really for quality and value. But in a certain sense, they probably should be accountable, obviously, to the beneficiaries too. And so the question is, is there a possibility of making it more of an enrollment model? And how? I know that would be complicated for a lot of them, but would that improve their ability to actually manage care?
Yeah, so attribution is important. Issues you're talking about, like leakage, are important. By leakage, I mean you're assigned to a particular ACO and you go outside the system to get your care, which frustrates the system that you're accountable for. You move, other things happen. There's certainly noise there. The enrollment system is complex because of how selection could play out. In other words, you could enroll some people and not others. It makes it more difficult to get all the benchmarks right. Although I do think there could be a role for some attestation of who your doctor is in particular ways that could help. I understand the desire to let individuals know and that they're in an ACO, and I think they should certainly be able to find that out. I wouldn't make it not transparent, but I would point out that most beneficiaries don't understand the financial incentives their providers are under provide the care that they're getting. So this is an extension of that general view, and I think the more transparency in that space, generally speaking, the better. What I would say is I am wary of making these models sort of purely attribution, purely enrollment type models, and then giving the organizations strong power about where, how they manage care or police care outside of their organizations, because of how it fits in with sort of the original fee-for-service Medicare statute and the way Medicare is. So solving the attribution problem, which will involve some more analytics and possible a role for naming who your physician is, maybe even incenting people to name who your physician group is. I think that is something that certainly needs to be on the table. But putting in people into a system where we're basically turning ACOs into Medicare Advantage plans and giving that ACO the same power that the Medicare Advantage plans have to build networks, deny care, particularly care for providers that they aren't, is, I think, much more of a challenge. And I prefer that type of model to be in the MA program. And if people want that type of model, they can join the MA program. And the MA program is designed in much, much better ways to allow beneficiaries to benefit from the efficiencies. They get their deductibles filled in. They get vision and dental and hearing, and all the efficiencies, it's natural to share with the beneficiaries in that context. To the extent that the ACOs can pair with MA plans or do things like that, I think we're sort of at the beginning of the journey to see what's possible. And I think it's important that we don't preclude those opportunities, but I wouldn't force them onto the system.
Very good, thank you. Back to some of the points you made at the very beginning, which were, I thought, excellent and something to emphasize, which is that Medicare has already made a lot of budgetary reductions in terms of savings from fee reductions for both the physician side and on the facility side. And to the extent that Medicare still has financial problems, it's going to be tough to keep going lower. I mean, there's always opportunities, and I know MedPAC knows this better than any other organization. There are always opportunities to find overpayments in the Medicare system. In a broad sense, though, given where we are with physicians and facilities, it seems hard to rely on pricing as the way to kind of get to a more cost-effective program. So given that, and given that MIPS looks like it might be more valuable for some physicians than some of the alternative payment model savings, how do we get out of the box that some physicians may just say to themselves, neither path is all that great. I may as well stay with the lower change that's required in MIPS.
Yeah, that's certainly true. And so, eventually I think physicians are going to want to find some ways to share the savings. Another way of saying that is we're going to have to eliminate the waste and someone's going to keep the savings. I think when money gets tight, in general, you want to be in a position to control the money. Maybe the short, I don't mean glib answer to your question, is we need to develop better benchmark setting systems. I believe we can develop a benchmark setting system which allows revenue to grow more slowly than projected under current law and allows providers to share in those savings. There are big differences by type of provider. So independent physician groups, which by the way have shown the most success under these alternative payment models because some of the underlying fee-for-service math is a little bit toxic for them, isn't as toxic if you're if you're in a small physician group. Or at least a physician group without a hospital. My joke has been if your goal is to keep people out of the hospital, it helps if you're not a hospital. But in any case, we can build benchmark systems that I think allow the savings to incent both participation and efficiency. And the main way of doing that broadly is to avoid the ratchet effect, avoid having, right now what often happens is if you perform very well in your first contract period, your benchmark in the second contract period is lower. Even if you get rid of that, if everybody collectively forms a lot better, everybody is just chasing the system down. That will help you maximize savings, but it really discourages participation because eventually you're going to lose. I think it's really the way to solve that problem is about getting the benchmark system correct, or at least better. Having an alternative fee-for-service system for people to be able to opt into, I do think for physicians to be able to stay in, I think is important. I just don't think that's going to be a particularly generous pathway. And so my personal view is you'll see much more innovation for organizations trying to help the physicians succeed so they can get a share of this waste, as opposed to just practicing under lower and lower fees in a real term. And just last point, the Medicare fee schedules collectively are scheduled to rise slightly below the rate of inflation for the next 10 years. So basically we're at inflation, and if inflation soars, it could be even worse, right? So we're just in a sub-inflation fee increase, and I think that's going to increasingly become a problem if people stay in that system, but maybe it's easier. So maybe some will do that.
Yeah. But I mean, so basically kind of boiling down what you just said, you think it's possible perhaps through revisiting how the benchmarks are set and maybe adjusting the portion that could be saved by the provider community, that the line for APMs could be above the MIPS line in effect.
Yes.
In terms of where it's going down the line without the money coming out of Medicare trust funds insolvency, so to speak.
Yeah, so I think creating a wedge between the APM benchmark, which is essentially a revenue number in the grand scheme of things, if you're thinking
Yeah.
ACOs, and where actually fee-for-service spending is important, because the key point is the fee-for-service spending that we observe will reflect ACO efforts to make the savings, and so that benchmark can rise lower than projected in current law, higher than we actually realize if the ACOs are successful, but the ACOs won't have to worry that we're going to grab all of it back. If it turns out to be, if there's really 30% waste in the system, which I don't think there is, but if there's really 30% waste in the system, and if the providers pull that out and there's windfalls, we can readjust where the benchmarks are, as we do for all other fee schedules. But for the most part, I think the current law trajectory could be set in a way that is flatter than current law and above what we actually realize if the providers are effective at getting rid of some of the waste.
Very interesting. I want to put you on the spot here by just going through some of the list of current APMs and see what maybe which ones you're willing to harmonize is a nice way of putting it, get rid of maybe. In other words, maybe, but the question might be, well, let me just list them here. So we have, of course, the multiple tracks now in the Medicare Shared Savings Program, MSSP. In addition to them, we have bundled payments for care improvement advanced model. We've got the joint replacement payment model, which you mentioned. The Trump administration created the comprehensive primary care plus model. They also created the primary care first payment model. Then there's the ESRD specific care model. And then two localities, Maryland and Vermont, have their own models. And then there's an oncology care model. And particularly with oncology, should we continue to pursue separately those disease-based models? Should we put all our eggs in the ACO basket, in other words? In other words, if we want to maximize provider integration, provider ability to really run an efficient model of care delivery, should we put more of our eggs in the ACO basket?
So the nice thing about talking to Jim is I realize you're going to push me, and I realize you're going to do it in public.
No, you're speaking in a health policy professor role. You know?
No, I understand. And since I can't see the audience, it's mildly less intimidating. But I'm going to give you maybe for that reason, I'll give you my general view. So first of all, I won't pretend to have all the answers or know the right thing to do. Second, I think the answer to that depends on the nature of the delivery system per se. So for example, for a large integrated delivery system that spans primary care and specialty care, I would try and put them, or at least strongly incent them, into a population-based model and not worry about disease-specific models, and allow them, there's a lot of nice features of direct contracting, allow them to build those models in what I call, actually a MedPAC commissioner, I hope he doesn't mind me saying, Brian DeBuck's coined this term, under the waterline. So they'll have a lot of flexibility to build how they engage the different parts of their system. And you could build all of that under the waterline. But the big system, which includes the primary care doctor specialists, the post-acute, all those things, they're sort of under a population-based model. When you move down to smaller physician practices, of which there are a lot and they're very important, you're not going to be able to impose the same risk. You're not going to be able to have the same impact on some of that other care that they have less control on. And for those organizations, you might have a model that is maybe closer to a primary care model with less population risk, and layer in on top of that disease models or other models for the type of specialty care. The challenge in general with trying to subset things by disease is, of course, many people have multiple diseases, and you have to worry that, well, the person with cancer also has heart disease. How are you dealing with the joints, the combined services? I don't want to say joints, but some of them also need joint replacements. In any case, it's hard to make that work. And if you pull all of the low-hanging fruit out of the population-based models and give it to a disease or an episode model, you disincentivize the population-based organizations for managing all the care that you would want to manage. So since so much money and spending is so skewed, and I know you've written this, so much money is in people with multiple chronic conditions and a lot of different episodes, it becomes very hard if you want organizations to try and address those complex, expensive patients, but they don't get the savings from a lot of what they do because you've now siphoned that off to someone who's getting their savings from cancer and some of them getting their savings from other places. So to the extent possible, I like the idea of building some of those disease-based models, what I would again call under the waterline, where organizations, they can contract with organizations to help them build things which works in their particular areas, as opposed to Medicare imposing it. But I think as you move down the scale of provider systems, from big systems to small practices, I think you will typically see a shift to less population-based risk and more episode disease-based models, allowing smaller organizations to choose the higher risk, more population-based approach if they want to, and they may do that. There'll be a lot of organizations that might aggregate them in ways that would make them want to be in that bigger model. So I think to summarize, and again, I will emphasize this is a Michael view, is very broadly, I like the idea of having a multi-track population-based model that has features of direct contracting and ACOs. We can talk about how that, but sort of a multi-track, think MSSP, but different. Multi-track model like MSSP, ranging from next gen type things at one end and CPC plus primary care things sort of at the other end. And then layering in episodes based on the nature of the track. How much population-based risk and responsibility is there, where you're using episodes more heavily in areas where there's less population-based risk, allowing some flexibility in what folks do. I'm glad this is recorded. I'll look at it later, so my next time I answer that question, it'll be smoother, but I hope that was clear.
No, that was good. That was very good. I'm sure the audience benefited as I did from that. Let me go back to this other thing you mentioned, a little bit sort of an aside about the relationship of ACOs and provider, what I would call provider-driven, provider-oriented managed care efforts in relationship to the MA program, which of course is now very large in Medicare. Yeah. Would it be worth our while? I mean, in some ways, there's always been a sense of in MA that it's an insurance-driven system, that the big players tend to be the big insurers who are running these plans in a model that that comes out of their commercial business that they then apply to the Medicare program. And I've always thought that there'd be space and maybe some popularity to a provider-driven subset of MA plans. In other words, kind of a hybrid of an MA and an ACO. Should CMMI, should others be trying to test and help promote full population-based, enrollment-based, kind of capitation-based, provider-driven managed care, maybe with some assistance on enrollment, some of the other capacities that they don't typically have? Would that be worth our while?
So, you know, we use labels like Medicare Advantage and ACOs in different ways. And I think it's important to break down what those things actually are. So let's talk with Medicare Advantage. And I think I mentioned, I'm generally speaking a big fan of Medicare Advantage. It is certainly enrollment based. It is an aside. Of course, you know, MedPAC, despite my liking Medicare Advantage, I do believe they're overpaid. We could have a discussion of that. But that being said, the core Medicare Advantage model is that they can engage providers and beneficiaries in different ways. Some of that is partnerships, and many of the Medicare Advantage plans I work with really are partners with the providers that they work with, but some of it's a little bit more like policing. They use utilization management, they use prior auth, they use a series of other tools to achieve some of the savings that they achieve. And we can debate how that plays out, and beneficiaries choose to be in that system in exchange for the added benefits that they get, and the MA plans have to work out their deals with providers. Outside of the MA program, the key question about building sort of a hybrid model you discuss is really about whether or not that organization has control, can use the same type of tools that MA plans use for care that's outside of their system. So for example, if I'm enrolled in a Capretta ACO model, and I go get care from a specialist that's not part of my particular ACO, can I use the MA tools to deny that care? Can I do prior auth? Can I manage that care that's outside of where I am? And I think that's where you run into problems when you try and take that notion into the traditional fee-for-service space. So the core difference is In MA, where people voluntarily choose it, or any, ACOs could partner with MA plans to offer particular things. So there's versions of which that could be done. But the key question is, in the fee-for-service side, where that person is not actively choosing something, would you allow some organization to use some of the stronger tools that MA plans might use, like prior auth? And I think, and then profit and capture the savings from that. Particularly if the person's attributed. If the person's enrolled, I generally say, well, that's basically an MA model. Let them compete in MA and let providers get into MA better. And I have no problem with any version of that discussion. We will have to change, if you're successful, we'll have to change the MA benchmarks because they're based on fee for service. And so there's a circularity of it. It wasn't built for its success. But the point is, I'm fine with that whole approach. When you're outside of that, where the enrollee is not choosing something, I get worried when you allow high-powered tools to manage care. The big difference in the ACO world is they're not doing prior auth or other those types of things outside of their system. So the beneficiary can always go to a specialist outside of the ACO, because the ACOs hate, and get the care that they might think they need if they feel like they're being rationed. They haven't chosen that trade-off, whereas in MA, they basically have. And that's the tension. Yeah,
very good. Thank you. I also want to go back to something you mentioned in your presentation, which intrigued me, and because I actually am not really sure I know the answer, which is you mentioned that basically fee for service is made to work in a lot of other countries, maybe not necessarily with all of this kind of ACO business that we're trying to implement, without shared savings models, without other things. It's obviously a big, complicated world out there and lots of different things going on. But in general, there's a lot of fee for service, and the payment rates are quite low compared to the US model. What is it about that allows them to have, at least in your mind, maybe better utilization even of the types of services? In other words, in the US model, one might expect, higher volume, frankly. So what is it you think about those other systems that allow them to use low fees and still make it work?
Well, I think, again, this is a much longer conversation. The whole labor market in those countries are different than our labor market. So the basic, it's very challenging to make direct comparisons. Yeah. So I want to be careful in doing that. The process that makes it work is, frankly, a lot more government involvement. They get everyone in the system, typically through a government program. It differs across the countries. They often have a budget for that program. They pay their providers differently. The real point is the providers generally accept, although most countries have some pressure valve where you can buy private insurance above and beyond the national system. It works differently in Australia than it does in the UK, than it does in Canada. But they're able in their system, both because look, Medicare pays a lot less than commercial rates as well. There's some value of, I don't want to use the word value, monopsony buying power has the ability to keep prices down in particular ways. You still have to make sure you get adequate care. Again, I'm not prepared to have a discussion about care in the US versus care in other places. I think typical quantity measures doesn't suggest that we get more care, doesn't suggest we get necessarily better care, but there's nuances to quality measure. There's nuance to how long you have to wait. There's nuances to a bunch of other basically issues about autonomy, about what role the government plays and what role the private sector plays. And we just have different views in the US about how that should work for our system writ large. So that's how I think other countries make it work. And I think it's hard to argue that we do demonstrably better. Some people argue we do demonstrably worse, at least if you measure dollars per some difficult measure outcome. There's other things we care about in our country. But I don't see us really going broadly there. And if you were to go in that direction in the US, what you're really doing is making a statement about how well you think central administration of the healthcare system would actually function in practice. The fact, my general view is government systems are flawed, market systems are flawed. You're comparing two imperfect systems and you have to kind of figure out how you think it will work. Usually the advocates of the market, in my opinion, downplay the problems with market functioning, and the advocates of the government-run systems downplay the challenges with making a government system work. And so you get the much more ideological, practical debate as opposed to what would work philosophically.
No, good points. You recently wrote a paper about ACOs, and on a topic that maybe a lot of people haven't thought about it in terms of how they get constructed, which is that a lot of times they're affiliating maybe providers who are loosely affiliated with each other to then kind of join together in an organization and operate in a market in ways where they still retain their separate organizational structure, their separate bottom lines. And does that potentially have an effect on consolidation and market pricing? In other words, outside of Medicare, in the commercial space, could ACOs be a vehicle for antitrust problems and over consolidation?
So I'm not good at short answers. The short answer is they could be. In that paper, we saw some evidence in a small set of cases of big price increases. Overall, I think there's so many forces driving consolidation in the American healthcare system that ACOs with the margin aren't making that big of a difference. Interestingly, there's a lot of work Uwe Reinhardt, Jerry Anderson, some others wrote, it's the price is stupid, which is a general point about the US system, but understand going forward, at least in terms of growth, in the commercial sector, it's prices largely. There's some, I spend a lot of time on low value care. There's some gain, there's inefficiency there as well, but prices are really the big deal. In Medicare, as you pointed out, prices are on a very low trajectory. Going forward, quantities are the big deal. The fact that, and the commercial side, the prices are affected by consolidation matters, and that's a whole other webinar about how to deal with the prices there. My personal view, since you asked, is transparency is important, but will get us nowhere close to solving the problem. It may in fact make things worse, but that's a longer story. Antitrust enforcement through the FTC is a really important thing. I'm not sure that will actually solve the problem for a bunch of reasons. So I actually think where there's super high prices, you're going to need some level of regulation on the commercial side. But again, that's not a Medicare thing. And Medicare, I don't think should dramatically change its policy because we have dysfunction on the commercial side. Our goal is to make Medicare payment work for Medicare.
Well, let me tease you out on that a little bit more. You're the expert on Medicare, and now we're wandering into the commercial space. But in terms of extension of Medicare into the commercial space, is that too big of a load to carry on Medicare's payment systems? In other words, when people worry about pricing in the commercial space, the solution, some of these states are already doing it, is to try to put some ceilings on it based on tying things to the rates that you're recommending to Congress. How do you, Colorado and Nevada and Washington State are already heading down this road. How do you feel about that?
So a few things. I think I've written with Limor Daphne Max Pani, a colleague of mine, for some work, the Hamilton Project, that I believe that there's some value in price caps in the commercial space where you think there is excessive pricing. I personally am not a huge fan of tying that to Medicare for a number of reasons, but basically you import all of the Medicare pricing dysfunctions into the commercial side. I like caps better than price setting because it allows the market to work underneath. For example, I view price caps on the commercial side. Sometimes we call them backstop price caps. In other words, you want the market to work if you can make it work, but sometimes it doesn't, and so you want to manage the higher prices. So that's kind of how I see that working. Tying it to Medicare is the administratively simple thing to do, and that's why I think everybody does it. I think it creates problems. And the last thing I'll say in the response to your question, and I think there's one question in the chat I'd like to say something about before we end, is the more fees you put, the more spending you put on the Medicare fee, and the lower you make those fees, the more pressure you put on provider revenues. In some sense, that is good. That's the whole point. Another sense, you can go too far. If everyone had Medicare fees, the provider revenue cuts would be dramatic. And you really have to think of the consequences of that. So I think I'm in favor of somewhat nimble regulation on the commercial side. And I personally would rather avoid tying everything to Medicare, but whether or not you do or not really has a lot to do with what you think about the role of government, the role of markets, and how much we want to collect to finance healthcare through taxes versus through premiums and markets. And that's a much bigger picture. Can I answer Neil's question?
Absolutely. Thank you for paying attention to that chat, to those questions, and please do.
I was waiting, Neil. So Neil asks, isn't Medicare Advantage really the best APM for Medicare? Then there's a bunch of other things I won't read because of time. But the short answer is Medicare Advantage might be better than traditional Medicare, in which case it should be able to win by attracting people to do that, and we should be able to pay Medicare Advantage fairly. I think that's my sort of Medicare Advantage comment. In terms of why I'm optimistic ACOs can do better, I believe they've created savings and they've not harmed quality. So again, I think they're a win. I think they've been designed in ways that are challenging. For example, the ratchet effect on the benchmarks I mentioned. So I think to the extent that Medicare Advantage doesn't win in the market by competing with traditional Medicare, we should try and pay in the traditional Medicare space in a manner that is supportive to providers and encourages efficient production of care. And that's where APMs are. It may be that at the end of the day, the Medicare Advantage plans can just outcompete any reasonable payment model in traditional Medicare, in which case all we need to do is come up with a Medicare Advantage program that isn't reliant on fee-for-service for its benchmarks. But I do think that's possible, and we should not be afraid of that if that's the way we're going to get beneficiaries to select plans and whatever. It's just that has to be a voluntary enrollment process. And so we need the traditional Medicare sector to exist and be as strong as possible for beneficiaries who don't want to enroll in Medicare Advantage.
Very good. Well, we're going to have you back, and this next time we'll get a neutral moderator, and you and I will debate a little bit more about premium support in Medicare and how that may or may not benefit the program. But Mike, I cannot thank you enough for devoting all this time to us and this very complicated and important topic. Your insights are very good and well worth hearing. So thanks so much again. We're out of time. I'm going to close the session now and just express my gratitude one more time to you for agreeing to participate in it.
I am honored to be invited, and thank you to the audience for their patience. And their joining.
Good. Thank you, Mike.
Sure.